Welcome to The Explainer. Today, we're going to put on our detective hats and create a kind of field guide for identifying the culprits behind one of the most painful problems in all of medicine, kidney stones. So here's our case file for today. We'll kick things off with the main players. Then we'll look at a really critical clue. After that, we'll profile two of the most notorious offenders. And finally, we'll decode some related evidence you might find. Okay, let's dive right in. All right, first up, let's get to know the lineup of the most common kidney stones you're going to encounter. You know, every good detective needs to know who the most frequent offender is. So what's the number one culprit you're going to see on your scans, time and time again? That's right, a whopping 75%. One single type of stone just absolutely dominates the scene. This table right here neatly summarizes our key suspects. So calcium oxalate, that's our 75% headliner, the one you'll run into most often. Then you've got struvite stones. These are linked to urinary tract infections, and you'll see them more often in women. Uric acid stones are the sneaky ones, and we'll definitely get to them later. And finally, you have the rare cystine stones, which usually point to some kind of underlying genetic condition. But listen, it's not just about what kind of stone it is. The size. Well, the size is a critical factor in figuring out what happens next. And here we see the two critical thresholds for treatment. If a stone is tiny, we're talking under 5 millimeters, there's a very good chance it's just going to pass on its own. But once it gets over a centimeter, the odds completely flip, and it's highly likely that some kind of intervention is going to be needed. Okay, now for our first special profile, a true supervillain of the kidneys collecting system, the struvite stone. I mean, you really can't get a more memorable description than that. We're not talking about little pebbles here. These things can grow into massive branching structures called staghorns that literally fill the entire inside of the kidney. It's an image you won't forget. So what makes these stones so insidious is how they form. They need alkaline urine to grow, and that's often caused by bacteria like Proteus. This means they can be forming quietly, in the background of a chronic infection. So the patient often shows up with a fever and some dull flank pain, not that classic sharp renal colic you might expect.
Next up in our case file is the master of disguise, the uric acid stone.
This stone presents a classic diagnostic challenge. See, it doesn't show up on a standard X-ray, which makes it kind of a ghost in the machine. So, how do we unmask this invisible culprit? The reason it's so incredibly vital to identify this specific stone is that it has a kind of superpower. It can be defeated with medicine. These stones form in acidic urine. So if you give therapy to make the urine more alkaline, you can literally melt the stone away. No surgery needed. You just can't do that with a calcium stone. And this is how we find it. On a CT scan, it tends to have a lower density, but the real giveaway, that comes with a special scan called dual energy CT. See, because uric acid is made of light elements, its density, what we call Hounsfield units, barely changes when you scan it at two different energy levels. Calcium stones, on the other hand, they show a much bigger change. They essentially light up differently and give away their identity. Finally, let's look at some related clues you might find. These are other types of calcifications in the kidney that aren't quite stones, but they're just as important to recognize. First is something called milk of calcium. Now, this isn't a solid stone, but a suspension of tiny calcium crystals floating in fluid. On an ultrasound, it creates this classic sign, a distinct fluid debris level that shifts when the patient changes position, just like sediment settling in a bottle. Next up is nephrocalcinosis, and this is a totally different process. Here, the calcium is being deposited into the actual tissue, the parenchyma of the kidney itself, not just sitting in the collecting system. Think of it as calcification of the kidney, not just in the kidney. Now, when this happens in the central part of the kidney, the medulla, these are the four most common culprits you've got to remember. There's a little bit of a debate about whether hyperparathyroidism or medullary sponge kidney is the true number one cause, but both are right at the top of the list, followed by long-term Lasix use and a condition called renal tubular acidosis. And here's one last piece of high-yield trivia for you. Medullary sponge kidney is a congenital condition, but its strange and seemingly random association with Beckwith-Wiedemann syndrome is one of those facts that doesn't quite make sense on the surface, which of course makes it a classic exam question. So what you should really take away from all this is a framework for identifying these culprits. The next time you see a scan, think like a detective. Start with the size, check the density on the CT, look for signs of infection, and just hunt for those telltale signs